welcome to our live training today. I'm really happy to have you all here. My name is Victoria Tippins, and I am a birth educator and student midwife and a birth worker. I've been attending birth for 15 years. About advocacy, when I took my doula training 15 years ago, it didn't really teach me anything about advocacy. And I remember being a doula in the birth space and providers saying, we need to do this thing, we need to do that thing. And they totally would bypass what my clients' preferences were and feeling like I have no idea what to do in that moment. And so throughout the years, I had to really choose to independently do this research and figure out like, okay, how do I navigate in a space where someone might want to do something a certain way? They have preferences for their birth, and then a provider might want to do something different. Also holding space for the evidence practice gap, recognizing that sometimes providers have recommendations that aren't totally based in research and evidence. So today I'm going to be presenting to all of you my favorite tips on how to advocate in labor. This is general information. With each one of these, I could talk about them for an hour or more easily. And so we're going to try to cram it all into an hour. So I don't want anyone to walk away from this feeling like, okay, I learned everything I need to know. Please keep learning. Please keep integrating. The difference between going into birth feeling confident and prepared to advocate and going into birth hoping for the best is like learning information and then being like, okay, I hope that it sticks, and really practicing it, really integrating it, right? Because doing that is what really helps us go into birth feeling like that information now lives in our body. It isn't something that we're pulling from our mind. So what is advocacy? Advocacy is saying, I want this thing, or saying, I don't want this thing. And everybody needs to advocate in birth because birth is a personalized experience. And so in birth, there are things that you might want that someone else doesn't want, and things that you don't want that other people do want. So on the conveyor belt model of care, where everyone gets on the conveyor belt and algorithms and policies have already made medical choices for you before you even walk in the door, research has found that approach does not improve outcomes compared to individualized care. Individualized care is when you are an active decision maker, right? You're making empowered, shared decisions with your care provider, working with care providers to be collaborative in your care, rather than feeling like things are just happening to you and you have to follow along this conveyor belt model of care. It is very common if you were to birth in a hospital, and I think it's good to prepare for this anyway if you're planning for an out of hospital, because sometimes out of hospital can transfer to hospital. It's common to walk in and just be told, this is what you do, and you can do that. And there's nothing wrong with any kind of choice that you make. And I'm not interested at all today in telling any of you what decisions you should be making, because I don't know what's best for you. I'm just here to give you evidence-based education, my own personal wisdom and tools to help you make your own informed choices in alignment with your values. Going into a hospital system where maybe they don't practice in a way that's very evidence-based. Every hospital is very, very, very different, but maybe if you're in that situation and providers are really wanting you to do this, that, and the other thing, you can always say no, or say, I want to do this thing instead. And that's okay. You know, you have the right to make whatever choices that you want to make for you and your baby. So personalized and individualized care, where we are taking into account the provider's wisdom and the provider's expertise and their recommendations. We're taking into consideration your body, your unique situation, your preferences, and also your intuition. That combination in decision making really supports outcomes in being better and experiences in being better too. And this kind of model of care is not handed to everyone or most people in the US, but it is something that you can create for yourself. It does require that you understand the benefits and the risks and the alternatives to the interventions available to you, so you can make your own informed choice. And it requires you to have the communication skills to be able to facilitate a collaborative care experience. In the midwifery model of care, that kind of care is handed to us. Typically, I mean, every midwife is different, and some midwives who work at hospitals have less time, have a busy schedule, don't spend as much time with you as maybe a midwife at a birth center or a home birth. So every midwife is different and every practice is different, but generally, midwifery model of care will be more individualized and take more time and consider, like, how are you feeling about that? What are your preferences? So every single provider is going to be a little bit different. And so either way, if it's handed to you or it's not, it's still important to learn how to facilitate that kind of care for yourself. So no matter what situation you are in, even if you're planning out of hospital and you end up transferring, you know what questions to ask. You are educated, and so you can, instead of entering the conveyor belt model of care, you can still hold intact an individualized model of care for yourself, and that will lead to a more positive birth experience. Let's talk about the evidence practice gap. What is that? The evidence practice gap means that it can take sometimes 10 or 20 years or more for new research and evidence to make its way into policy and practice. For example, we all know that birthing on your back is not the best, right? That's not the best position to be in. 95% of moms in the US give birth on their back, and it's very well researched that birthing on your back really isn't ideal and does not improve outcomes for mothers or babies. It increases your risk for C-section, it increases your risk for tearing. And still, that is one of the most common positions. So that's just one example. Another example is, let's say your water breaks before you go into labor. This happens 10% of the time, so it's not common, but it can happen. If your water breaks before you start having contractions, if you're planning a hospital birth, you likely will call and say, my water's broken, and then they will say, oh, come in immediately. We have to get you on Pitocin to induce your labor. Possibly without even illustrating the risks or the benefits or alternatives, right, to Pitocin. If a mom is wanting an unmedicated birth and then goes into the hospital and gets Pitocin, Pitocin is going to make contractions likely more painful. And then the mom might end up getting an epidural. And it might take that parent down a path that they didn't want to go down, and they never knew that they had any other options. But research and evidence says that if your water breaks at term, so you're 36, 37 weeks and beyond, you don't have GBS, which is a bacteria that can be found in the vagina at the end of pregnancy that they'll test you for. Research says if you don't have GBS in your term, obviously the fluid is clear and the baby's moving normally, everything looks good. It is an evidence-based choice to wait for spontaneous labor for 48 to 72 hours. So you can wait quite a long time after your water breaks before contractions start. And I'm not telling anyone to wait that long. I'm just illustrating that that's what evidence-based birth says and what the research says for that. And so you have a lot of options. If your water were to break, you could go into spontaneous labor soon. If you don't, you could go get Pitocin. You could induce naturally at home. Or you could wait and say, like, let's reassess tomorrow. But hospitals, many of them, want you to come in immediately and start Pitocin because of outdated research around infection risk. Back when we were doing way more cervical exams than we normally do, or even before when providers were not washing their hands in the later 1800s and spreading infections to people. So obviously that is not our situation today, and still we're still in the mid 1900s when we were doing tons of cervical exams, which increased the risk for infection dramatically. So just having that information and that education on all of those options opens up your options significantly. It really does. I cannot go over all of those obviously today because I could speak about every single intervention and what the research has to say for a full hour on each one. If any of you are interested in joining my coaching program or working with me, that is where we will go over all of that. I see some of you have, I know you, we've been talking, have booked a call with me. And if you haven't, there's the link to do so if you want, so that you can do this free birth breakthrough session with me. And on the call, we'll just talk about what are the things needed for you to feel confident and prepared for birth? Where are the gaps in your knowledge specifically? And how can I support you in getting to a place where you're like, okay, yes, I feel so confident and so prepared for my birth. So I'll clarify what those steps are for you and create that plan. And then we can talk about and see if my coaching program would be a good fit for you. So I'll say really quick that general education will tell you about your rights, but personal birth coaches help you figure out the exact strategy to execute those rights. So it's kind of like a difference between getting information, and information lives in your head. And then when you're in labor, your thinking brain turns off. So it can only take us so far. But integration and personalization helps you to apply all the things you learn to your specific situation and can help you with the information overload, because often moms will come to me and they'll be like, I have learned so much, but it's all in here and I have no idea how to apply it to my situation, what's important for me to do and what's not. And with advocacy, every single hospital, provider, birthing location is so different and has different bias, different policies, and different things that you might have to navigate. And so some providers might have this like really big baby bias, and they are so terrified of big babies and they're putting a lot of fear into you, in which case like having a customized plan to reduce your risk for tearing, to reduce your risk of induction, or support your body and going into labor sooner naturally if that's what you want, like might be helpful. If you have a provider with a high episiotomy rate, it might be important to implement evidence-based tools to reduce your risk of episiotomy specifically with that provider. If your provider doesn't have a high episiotomy rate, then it might not be as important to make some of those choices, if that makes sense. So learning information is great, but getting birth coaching support gives you a customized plan how to navigate your specific situation with your provider, understanding what questions to ask to even understand how is their practice evidence-based and how is it not? Where's the evidence practice gap? How is that not lining up with my preferences, and what are we going to do about it to protect me? So now let's go deeper into what your rights are and what consent is. So you have, first off, the legal right to informed consent and informed refusal. And so that means that you can say no to anything that you don't want. This is confusing for a lot of parents though, because maybe they know that they have that right, but then a nurse might say, I'm going to check you now. Or a provider might say, we're going to give you Pitocin. Or it might just turn to the nurse and say, put her on Pitocin. And it's like, hello, I'm a person and I'm the one who's going to experience this thing. Can we have a conversation about it? That can feel hard if you're a person who doesn't have the nervous system capacity to really advocate, or kind of shuts down or gets anxious in the presence of providers. I personally struggle with my nervous system capacity with providers, but I have tools to help me navigate it. I have tools to help me communicate, and I have worked on that nervous system capacity and made it so much more possible for me to feel comfortable and confident. If I were to give birth in a really intervention heavy hospital with a large evidence practice gap right now, I'd be like, I'm going to be good because I know all the things and I've built the emotional preparation to be able to do that. But when it comes to informed consent and refusal, sometimes moms are like, you are telling me I need to do a thing and you're the provider, so I guess I have to do that thing. And then maybe the birth partner, someone who is like, I won't let anything happen to you, and like, I've got you, like we've got all the confidence, which is great, but then like you're also vulnerable. You've also been up all night and you're hungry and you're experiencing something that is really like special and intimate, and maybe even scary. Having a baby come into the world, and then someone says, I think something's wrong with the baby's heart rate. We should do a C-section. And you're like, like, I don't want to have anything wrong happen to the baby. So yes, we should do what you say. And sometimes that information can go out the window. So understanding what informed consent is, and as a birth advocate, as a support person or partner or doula, understanding how to support informed consent being intact is really important. So I like to say, if you are a birth partner, one of the best things that you can do in your role is to just oversee informed consent being intact. So that means if at any point at all you have a funny feeling in your tummy and you're like, what's going on? Or like, the provider just said we should start doing this thing, or I'm going to check you, or whatever. And you're like, that feels weird to me. Is that like an okay thing? Do we talk about that? Like, if you feel that feeling at all, say something. Be annoying about it. It's worth it. Like, if you were to be like, oh, I see that you're doing this thing. Honey, are you okay with that? And then maybe the person giving birth is like, yeah, we already talked about it. Like, catch up, It's like, fine. It's worth looking like a silly person who like wasn't paying attention to just make sure that you are like feeling confident about everything happening. Because chances are, if you as the birth partner or support person are not feeling confident about something, or not feeling like informed consent is intact, probably the person giving birth is not feeling like informed consent is intact either. So if you have any funny feeling, instead of talking yourself out of it and being like, it's fine, the provider knows what they're doing, like I shouldn't be, if you notice that in yourself, just stop yourself and just say, hey, wait a second. Is everything good here? Did you consent to that? Can we have a conversation about this? Wait, I'm not really understanding what's going on. Could you explain it again? Can we take a moment, right? Just say something. That's really important. And then if a care provider says, yes, well, we have to do this thing, blah, 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 blah. Maybe the mom is like, okay, sure, maybe I'll do that. And you're kind of looking at the mom and seeing that the mom is like, I don't really want to do this, but I guess I have to. And like maybe not seeming really confident about that choice. You can always say, you can decline. As a birth partner, you can help to invite the mom to remember that they have the right to say no. Because informed consent means that you understand the risks, the benefits, and the alternatives. You understand that you can say no. That's really, really important. So you can understand all the information, but if you're feeling pressured and a provider says there's a problem, you need to solve it my way, you might be like, oh, I guess I have to solve it your way. And if someone reminds you, like, you can say no. We want you to know you can say no before you consent. Otherwise, that's being pressured into something. That's not consent. Consent is of your own free will. I know I can say no and I'm choosing to say yes, right? So some ways a birth partner can support is to help make sure that informed consent is intact by honoring their own intuition, by facilitating conversations. What are the risks and benefits, alternatives? Can you give us that information? Reminding the person giving birth that they can say no. That's kind of like a little overview of advocacy and informed consent. So I want to transition here soon into step 1, which is risks, benefits, and alternatives. And we're going to go over we're going to go over Pitocin. I first just wanted to offer or just share a little bit about the outcomes for my students who worked with me in my coaching program around interventions. So I surveyed the first 100 and I found that they had a outcome of reducing or avoiding unwanted interventions at 9 times better than the national average. So 100% avoided episiotomy, 96% avoided an epidural, 96% avoided a C-section, had a vaginal birth, 97% avoided Pitocin, and 97% avoided an IV in labor. It's not like avoiding an intervention is like something to, is like the ultimate goal. The ultimate goal is that you're making informed choices in alignment with your values. And I just happen to attract a lot of people who want to make choices to reduce the risk for unwanted interventions. And so I wanted to illustrate that as an example and an invitation to you to go beyond just a generic birth class where you're just learning the information. Because like I said before, information lives in your mind. We need emotional preparation, personalization, custom advocacy plans. We need to integrate what it is that we know. So rather than cramming information in your brain at the end of pregnancy, we're learning it slowly over time and we're implementing it and integrating it and practicing it and customizing it to you and personalizing it to you and your preferences. We have studies on birth education in the United States. It's very interesting. And there was one big study that came out that said parents going in to a weekend hospital birth class wanted to learn risks and benefits and alternatives to interventions. And then they surveyed the parents at the end of the class and they could not answer anything right. Because like, I don't know, you've taken a class, you listened to a podcast before, you're listening to this training, like you will walk away from this with a lot of new information and the training is going to be so helpful for you. Like in a class, like you'll learn a bunch of stuff, but then how are you going to apply all that? And how are you going to remember all of it? Like I feel like I take away about 30% of a class, right? I'm not like, I can't just repeat that class now to all these people. I have to like learn it again and practice it and integrate it to be able to turn around and actually like teach it myself or implement it myself. So yeah, I'm offering that just to show you what can happen, like what's possible when we take an alternative approach to childbirth education that involves personalized support and integration, not just information. So let's go into number 1, which is the risks, benefits, and alternatives. If you understand risks, benefits, and alternatives, then you can never feel backed into a corner, because parents often feel backed into a corner during birth because someone will say, you need to do this thing, there's a problem. And then they're like, oh, there's a problem, I guess I have to do this thing. But if you understand like what is the medical indication to be on your back, you understand what the reasons are to be on your back. And so if someone says you have to be on your back, you can go, well, is it one of these reasons? No? Okay. Like I'm educated, I understand that. If someone says, I think that you need a C-section because I'm worried about the baby's heart rate, you could say, are there alternatives that we can explore? I know what those alternatives are, and you can bring them up and have a conversation. We're not just at the whim of whatever information a provider wants to give us in the moment, because sometimes information can be swayed to try to get us to do a thing that they want us to do. And that's not always true. Some providers are really great at expressing information in a full capacity, and other times providers are not so good at that because they want you to do the thing that they want you to do. So you can protect yourself from ever experiencing that by just having that education. So let's talk a little bit about Pitocin. Pitocin is the synthetic form of oxytocin. It is very common. 1 in every 3 moms will have an induction in the United States, which is alarmingly high. And Pitocin is the most common medication that is used for an induction, which is we're doing something to get your labor started. Pitocin is a really helpful tool and can be life-saving in the case of a hemorrhage, can also help with induction if induction is needed, can help augment labor, which means it makes labor continue or speed up. And in many cases, it can be a super helpful tool to have someone have a healthy birth. And it has risks and it can be overused. So the benefits of Pitocin is that it can get your uterus to contract. Sometimes in an induction, if your body is just not ready, you could get Pitocin for a while and maybe nothing will happen for, a whole day. Maybe you go home and come back again and then try again. And so it's not like it works right away for everybody. Some people need just a little bit of Pitocin. Other people need a lot of Pitocin. And so it really depends. Like if you were to get Pitocin, just know that it's important to have collaboration around how much Pitocin you're getting, because a nurse might come and increase your Pitocin a little bit every 20 minutes or so. And perhaps after we get to the desired effect, which means you're having consistent contractions and you're officially in active labor, or maybe your labor stalled and now it's picked back up and it's working again. But maybe we continue to up it and up it and up it and up it. Do we have to keep upping it if you have already reached the desired effect for Pitocin? No, we should keep giving it to you probably, unless the baby shows signs that they're not doing well with it anymore. And you can always advocate to turn your Pitocin down or even turn it off and see if contractions continue if that's something that you want, because sometimes it can get something started and then it isn't needed all throughout labor, and other times it is needed. It has a really short shelf life, so it basically processes through your body quickly, which is why they keep giving you. But if they're giving you 5, if they get you up to 5, and so it's like, yay, you're at 5 and now it's working and you're in labor, do we need to bring you all the way up to 15? No, we can keep you at 5. That's great. If you're at 5 and you're not getting anything at all, we should probably keep increasing it until we get to maybe 10 or 15 or wherever we need to go for it to work for you. A lot of parents don't know this, and so they'll say, okay, I consent to Pitocin, and then they're given so much more than maybe they actually need. So it's important that if you want Pitocin and if you want to be collaborative in this experience of having it, you could ask them to start at the lowest dose possible. And you could make it clear that every time it's going to be increased, we need you to give your verbal consent. I consent to this number, 1. We're starting at 1. I consent to 1. Do not give me more until I consent to more. And they would come in and then hopefully they're supposed to ask for your consent. If they don't, there are people hopefully in your space that can support you in advocating for that. If you feel like that's going to drive me crazy to have to keep every 20 minutes talk to someone about it, you could say once it reached the desired effect, let's just check back in. And I want to check in and just see how things are going before we increase it after that. You can say that too. And I think it would be good to put this on your birth plan. If you're thinking about getting Pitocin, a lot of people don't plan for Pitocin but might get it anyway. So I think it's good to put it on there just in case that were to happen. The risks to Pitocin is that Pitocin can make your labor more painful. The molecules are too big to cross the blood-brain barrier. So that basically means that in a normal contraction, your body releases oxytocin, which is your love hormone, and that causes your uterus to contract. Yay. When your uterus contracts, your body releases endorphins, which are your own pain-killing chemicals, to help you cope with the contraction. And there's this perfect feedback loop woven into place, and it's very, very cool. So it basically means that your body isn't going to give you a contraction that it can't handle, because your body creates the contraction, and then your body is experiencing what it creates. So it gives you what you need to be able to tolerate every contraction. When you have Pitocin, that normal feedback loop is skipped over. And so you're getting the synthetically stimulated contraction without the same amount of endorphins that you would get in a normal contraction. So you're getting the pain without as many endorphins, and it can make labor more painful. I do know moms who have had unmedicated births with Pitocin. You absolutely can do that, but just know that it is common for moms to want pain management. It's okay if you want pain management, but if you're a person who doesn't want pain management, it might be ideal maybe to explore other options for induction or augmentation if the Pitocin is put on the table, for example. Other risk to Pitocin is that it can cause your uterus to contract a lot, and this is called a uterine tachysystole. So your uterus just goes contract, 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 a little overstimulated, and we're just going to contract a ton. That can lead to fetal distress. Very rarely it could lead to uterine rupture or something more significant. that would be a situation and a life-threatening situation, but that's very, very, very rare. Another rare side effect to Pitocin, but something that can happen, is the opposite, and it's called oxytocin receptor downregulation. And it basically means that your oxytocin receptors all around your uterus are like, and we're done. We're so overwhelmed, we quit, and we're just gonna fall asleep now. Like, we cannot handle any more oxytocin or Pitocin. And so that makes your uterus not very responsive to Pitocin or your own oxytocin anymore. And this does increase the risk for hemorrhage. So inductions do come with an increased risk for hemorrhage. Pitocin can also cause swelling, and so that can cause your nipples to flatten, and a flat nipple makes it a little bit harder for latching. A Pitocin also usually, it will involve like an IV, right? They'll put the Pitocin in the IV fluids, and Pitocin, anything that can cause swelling, can increase your risk for tearing, because putting more fluid into your body can cause the perineum to swell, which can increase the risk for tearing. So those are the risks associated to Pitocin in labor. There are less risks when you're using a little bit of it to augment labor, more risks when you're using lots of it to induce labor. So next, which is communication tools. So let's say that a provider comes into your room and they say, your labor's taken a while. I think that we need to give you some Pitocin to speed it up. And like, that can be a valid choice sometimes. And it's also important to recognize that the normal labor curve, which is, or maybe I'll say the most common labor curve, which is the Friedman's curve. It comes from the 1950s when a provider named Dr. Friedman performed non-consensual cervical exams to 500 white women in a hospital in Boston, and when they were put to sleep through labor with a mix of morphine and scopolamine. And then he said, this is how everyone should dilate in labor for the whole world. And everyone said, yes, we agree. And in 2014, ACOG updated their guidelines so that it allows more time in labor, and based on new research. And then new studies came out showing that in the US, about half of OBs are still following the Friedman's curve, which means that we are not giving you as much time as we should in labor and jumping to C-section. And failure to progress is the top reason that C-sections happen. So it is like needing to augment and speed labor up. Sometimes it comes from an evidence-based place, sometimes it doesn't. And if you're in my coaching program, you'll learn that. So you're educated in that moment. But let's use this example for BRAIN. So BRAIN is an acronym to help you facilitate being collaborative in your care and having a conversation about it instead of feeling like, there's a problem and I have to do something about it. So B, what are the benefits of Pitocin? We just learned that. R, what are the risks? And then A, what are the alternatives? Could we try position changes? What if there's a positioning issue? Maybe the baby isn't well applied to my cervix. If you're in my coaching program, you'll learn if someone does a cervical exam and says your baby's high up, your baby's asynclitic, tilted to the side, your baby's facing forward, posterior, which sometimes causes problems, sometimes does not at all, what to do about it. And that can often be the reason why labor is stalling, because the baby isn't in a really ideal position. So we know how to resolve that. So what about positioning issues? What if I release my own oxytocin? Could I get in the shower and y'all can leave me alone for a little bit? Can I get my partner in the shower with me? We can kiss and cuddle and skin to skin. What about pumping? Can you bring me a breast pump? Breast pumping can augment labor. So understanding the alternatives is really, really important so you can facilitate that conversation. The next is I. What does your intuition have to say? How do I feel about this thing? So in the presence of this choice, do I feel like, my throat feels tight and my belly feels tight and my chest hurts and I don't feel good? Maybe that's not the right choice for you. But in the presence of this choice, if you feel more relaxed and you're like, yes, this feels good, this is the right choice for me, maybe that is the right choice for you. So checking in with your intuition is really important. And the next is N. What about doing nothing? You can say no, right? It goes back to the beginning when we were talking about informed consent, which means that you understand that stuff and you know that you can say no. So BRAIN really encapsulates informed consent. And this is important because a lot of parents forget that they can say no. And so someone will say, there's a problem and you need to solve it. And they're like, I guess I have to figure out a way to solve it. But what if I don't? What if I just keep going as I go, as I already have been? And the provider might say, well, then I'll just check in with you in an hour. Oh, okay. That's easy. I didn't even realize. So it's important to remember that you can ask, what about saying no too? Another tool for communication that I want to teach would be to ask the provider to leave the room. And to first obviously make sure there isn't an emergency happening. So if you're not sure, you can say, is this an emergency or do I have a few minutes, right? And just get that clarity. And if the provider says like, yeah, we should do something about this soon, but like, yeah, you have a few minutes, or it's not an emergency, but it is important, you could ask the provider to leave the room. Asking a provider to leave the room gives you a few moments to check in with how you feel about something, because it can be really hard in a vulnerable experience to really get clear on how you feel about a thing in the presence of the person who wants you to do that thing. So ask the provider to leave the room so you can check in with yourself and see, how am I really feeling about this thing? Next, let's talk about another tool, which would be to decline again. So it is common for a provider to say, you have to do something, for you to say no, and then for them to say, but you have to do it. Because we're so used as care providers to just doing this conveyor belt model of care, and maybe don't see people who want to say no to things very often, or no to the things that we want them to do. Some providers can be really personally offended that, you don't want to do the thing that they want you to do. So it can be, I think it's important that you are prepared to say no again, because a lot of parents will say no, provider will say you can't say no, and then it's like, wait, can I not say no? And it can feel really overwhelming. So if a provider comes in and you're pushing and they say, okay, Sarah, time to get on your back for pushing or whatever, you could say, or your support person could say, oh no, she's staying on hands and knees. And the provider might say, oh, but no, you have to get on your back. That's how we do things around here or whatever. Then you could just decline again. So you just say, we said no. Thanks for taking care of us. Boom, done, simple. Just like, nope, we said no. It doesn't have to be an argument. You don't have to like have a whole conversation to try to get your point across or have them understand what the research has to say. Don't try to change their mind. Just tell them, we said no, and that's all that you have to say. The next tool I want to talk about would be for delivery. And this is specifically for a birth partner or a doula or advocate, right? So say a provider comes in, and maybe if you have an epidural, or maybe if you don't, but it's, I think, even more likely with an epidural if you can't feel what's going on, it's important for someone to kind of just hold some awareness around what's going on with your body during pushing, because pushing is a time where many providers think it's okay to just insert their fingers in your vagina or bring an instrument to your body without your consent or knowledge, and that is not okay. That's obstetric abuse. Doing a procedure to your body without your informed consent is obstetric abuse, and it's not an acceptable way to treat someone in labor. And it's unfortunately, I don't want to say like really common, but it does happen. Cervical exams, I would say, are much more common. So let's say you're lying on your side and you're pushing, provider comes in and they say, I'm going to check you now, and just reach to do an exam to like see if the baby's head is there or something. This is where it might be hard for you to say something, especially if you're having contractions, because moms, when they're having contractions and an unmedicated birth, cannot talk at all. So a support person could say, oh, hey, I see you're going to do an exam. Are you okay with that, honey? Or like, Sarah, are you okay with that? Did you like, if speaking up in that moment and just vocalize what the provider is doing? I see you're going to do an exam. If the provider picks up scissors or an instrument, just say, oh, I see you're picking up scissors. Instrument. What is that for? Do you know, Sarah, providers doing? Do you have questions about that? Did you consent to that? Right. Just like bringing that up and saying anything that you see is important. And honoring your instincts. Like I said before, if you ever have that funny feeling, just speak up. But specifically in this communication tool, say whatever you see happening. I see you're upping her medication. Did you say that it was okay to do that? Oh, you didn't? Okay, well, let's have a conversation. Can you not do that? And we'll like talk about it first. Right. These things can just become so routine. They can just like happen without telling you or checking in with you first. So just say what you see. The next one would be to request a new nurse. So I recommend everyone make a birth plan. In my coaching program, you'll get your birth plan made by me. Once a month, I have a free birth plan building workshop. So I won't make your birth plan, but I'll kind of go over the birth plan template, and you can kind of like listen and write it as you, if you want to do that. Have your birth plan. Your birth plan is not an illustration of how things will go, but it is an advocacy tool. So it just writes down like on one page what your preferences are, using language to keep the power in your hands. And my birth plan template, which is free, is a great one to follow because it uses all that kind of language that's more firm. Sometimes we don't need to use very firm language and other times we do, and it just depends on your provider and the way that they practice. So I would have your birth plan in hand, printed out. When you arrive at the birth center or hospital, if you have a midwife at your home, just like have it on the counter in case you were to transfer, so we can bring it just in case. But if you arrive at the birth facility, say, hello nurse, or hello assistant midwife, here is the birth plan, and hand it to them. In a birth center with an assistant midwife, probably they already know you, they already know your preferences, they probably already align with your preferences, so I don't think it's as important with them, but I think it's still good to have it printed out and bring it, because care providers at 2 a.m, even midwives who really know you might forget little things, so I think it's good to have. But in a hospital, you'll be meeting that nurse for the first time probably, so hand the nurse the birth plan, and support person should say, can we just take a minute to go through this birth plan together? That would mean so much to us if you could help us in having these preferences be intact. Your nurse can help you advocate. And if your nurse looks at the birth plan and maybe you go over a few points like, see, she's having an unmedicated birth, please don't suggest pain medication. Also, she really wants like provider hands off, or she really wants to birth in an upright position, something like that. Like, that's really important to us. Can you support us with this? And if the nurse goes, I don't really like supporting people in upright birth. That recently happened to one of my clients, but she knew how to navigate the situation. They got a new nurse and it was fine. But if she didn't know that, she would have been with that nurse, and that's like really not ideal. So if you get anything snarky back from that nurse immediately, okay, good to know, you're not a good fit for me. And we're going to figure that out now before we're actually delivering a baby. And it's hard to get a new nurse at that point if a baby's coming out. Don't have time for that. So you can have a support person go out to the nurse's station and say, can I please speak to the charge nurse? Charge nurse comes out and say, hello, charge nurse. I'm Victoria, and my doula client just feels like it's not a great fit with this nurse. It's like a personality thing. We really, or you could say that, or you could say, we really want to have someone who can support us in having an upright birth, and the nurse made it clear that she doesn't really support that. Is there someone else that we could have as our nurse that might be a better fit for us? Thank you so much. I really appreciate you doing that for us, right? So just like have a quick conversation and ask for a new nurse. If you're worried about your provider not being a good fit for you, if you're with a big OB group that rotates, you can look up if your hospital in their patient bill of rights allows you in labor to get a new provider, because sometimes they do and sometimes they don't. But if you can get a new provider in labor, that's such a huge game changer, because if a provider comes in and they're just like really disrespectful, that's not common, but it can happen. You don't feel safe in their presence. It is absolutely within your right, if the hospital illustrates it's within your right, to trust a new provider. I recommend that you learn about that beforehand, just so you know and you have that information before. The next thing that I want to talk about would be monitoring. So there is intermittent monitoring, which is a safe and evidence-based way to monitor your baby throughout labor, where someone will monitor intermittently with a Doppler every 15 to 30 minutes. And then there is continuous monitoring, where we're listening to the baby's heart rate continuously all throughout labor. And with continuous monitoring, whether it is external with the straps around your belly or internal, either way, it comes with an increased risk for a C-section. Even if the external monitors are wireless, they come with an increased risk for a C-section, because there are many shades of gray in obstetrics. Your baby has a normal heart rate variation from 110 to 160, and so your baby will find a baseline around 130, and then you have a contraction and the baby's heart rate will change a little bit. It will go a little up. At the end of labor, it goes a little down, and then it will come back up to baseline. That's normal. But if your baby's heart rate goes down a little bit lower than it did before, still in the range of normal, but maybe it's a little lower, or maybe it takes a little longer to come back up. If we're listening all the time to every little thing, we might see something and interpret that as an issue, even though maybe it's not. Research and evidence has found that continuous monitoring increases your risk for a C-section without improving outcomes for babies. So unnecessary C-sections are more likely, if that makes sense. So if you were to be getting continuous monitoring, going back to advocacy, and a provider comes in, which is a possibility, and one of my mamas in my coaching program weeks ago. She just avoided a C-section and an episiotomy actually because she knew how to advocate against episiotomy and against a C-section in a non-emergency situation. And she used all of those tools. And so the provider for her said to her, I think your baby's heart rate is like kind of going down a little bit. I'm not that confident that you should continue a vaginal birth. Maybe we should think about C-section. And she was like, well, then I'm going to be doing alternatives. Like I'm going to get in upright positions. I want an amnio infusion. These are different options that you can consider to help with the baby's heart rate and help the heart rate improve. Hands and knees is one of the best things that you can do to help with a baby's heart rate if there's any cord compression or something like that. An amnio infusion is a tube that will be placed past your cervix into the uterus, and sterile fluid will flow into the uterus, and that creates a cushion around the baby's head, and that can really help with their heart rate. So she was really advocating for that. What the midwife which is surprising, was advocating for was for her to be on her back so they could use the external monitor and hold it on better, because in hands and knees it kept slipping and the nurse had to keep coming in and fixing it. But she was like, if I'm on my back, it's going to compress on a blood vessel that runs behind my uterus. I know that. It's going to increase my risk for C-section. So you're saying that we need to do more monitoring and like monitor better, and you guys don't want to keep coming in here to fix it. But what I'm saying is that maybe you're going to have to do that. That's the care that I'm going to need because I'm choosing to birth in an upright position, to labor in an upright position. And I know that hands and knees is going to help. And she didn't have this whole conversation with them. She was just like, no, I want to do this thing. You know, she made it really simple, which is what I teach to do. But she had that education beforehand, and that prevented her from having a C-section. So if this were to come up, you can advocate for those alternatives. You can also say, if you're not that sure, you can say, okay, are you not reassured? Because the language that's used with monitoring is reassuring or not reassuring. Not reassuring means that like we're worried about something and it's a problem. Reassured means everything's good. But then there's not so sure in the middle. And providers, because like parents have 18 years to sue, it's like the most highly sued profession. They're going to lean towards liability. So if we're worried about something in the heart rate, we're going to probably lean towards a C-section, because if something does end up being a problem and then I didn't give you a C-section, then like you could sue me. So we're going to lean towards that. So if this were to come up, you could say, okay, are you like not reassured or are you not so sure? And if they say, I'm not reassured, I'm really concerned, this isn't like, I think this is becoming an emergency, that's obviously a different conversation. If they say, I'm not so sure, you could say, okay, well, it sounds like this isn't an emergency. Let's explore some alternatives. And even if a provider was like kind of more concerned, you can still explore alternatives too if you want. What's important is that you understand these communication tools. You use brain, you have a conversation. And if there's any lack of clarity around how urgent something is, just clarify. Is this a right now emergency, or do we have time to have a conversation about it? So those are some tools for communication. Let's go to step 3 next, which is understanding bias and how to navigate it. Bias is really, unfortunately, common in the Western medical model. Providers can have bias around larger bodied people, around big babies, around LGBTQI+ families, same-sex partnerships. They could have bias around income demographic and also race. And racial bias is what contributes to Black maternal health outcomes being so much worse than white maternal health outcomes. We are in the middle of a Black maternal health crisis in the United States. So here's just a list of some things that everyone should know, but especially mamas of color who are navigating a bias system. Number 1 is to understand the AWHONN safety standards. It's AWHONN. And you can ask your hospital if you're interviewing hospitals. Everyone has different access to hospitals. Some have like lots of choices and others don't have as much. But you can ask your hospital, do you follow the AWHONN safety standards? Because the safe patient to nurse ratio should be 1-to-1. And some hospitals will have one nurse taking care of multiple people to save money, but that doesn't make you very safe, right? It's not a very safe situation for you. So knowing if your hospital does that, I think is a really important thing if you're considering birthing in that location. You can also use the document refusal strategy. So that means that if you say, I request this thing, I'm worried about this thing, I want you to do something about it, and then someone says, no, I think you're fine, you can say, can you document that I requested this thing and you refused in my chart? Because if that accountability is there, that inspires care providers often to take action. There's also the Kick Count app. I recommend everyone gets the Kick Count app, and it is an app that you can use in the third trimester to track your baby's movement. It's kind of fun to use. You can like hit a button whenever you feel your baby do a movement, not a hiccup, but like a elbow jab and a knee jab and a kick and something like that, any of those movements. Pick one time during the day where your baby is most active. You can lie down on the couch, on your side, or just sit down somewhere and maybe just be still and let your baby move. Baby's more likely to move when you're resting, and just wait. And within 60 minutes, we want your baby to have 10 movements and track those movements. The purpose of tracking on the Kick Count app is that sometimes anyone, but especially mamas of color, can go into maybe the ER and say, I'm really worried about my baby not moving. And they might say, we don't believe you. You're fine. It's normal for your baby to move less at the end of pregnancy. In which case, you have data and you can say, look at the data. I have data I've been tracking, and you see how on this graph, because it gives you a graph in the app, my baby's movement is not the same as it used to be. And they might see that and go, okay, maybe we'll believe the data over you, which is horrible. And still, this is a way that we can navigate some of that. The next would be to consider birthing in the midwifery model of care. The midwifery model of care has been shown to be more personalized. It's a safe and evidence-based model of care that can improve outcomes for mothers and for babies, because in that model of care, we build trust and we spend more time with patients. There's more postpartum care for the mom. The mom gets often, every midwife is different, but often the mom and the baby will get at-home visits for 6 weeks. And in the OB model of care, you only have to, you get one, appointment at your 6-week checkup, and no one is taking care of you, which is absolutely bananas. And if you're birthing in the hospital model of care, but you want midwifery postpartum support, you can consider hiring a midwife in your community to give you postpartum support, if that's something that you want. The next would be to get a designated advocate. So have someone in your birth space, a doula, or a friend or your mother or your partner, but that person is clear. They understand it's their role to be your advocate and to communicate for you if needed, to support you in being collaborative in your care, to facilitate conversations between care providers, or you and your care provider. And hopefully that person can be educated, can learn some things beforehand, and have a set of tools that they can use to support you with that. Exercise your right to refusal and to decline. You are not a guinea pig, you're not a teaching model. Hospitals that use people giving birth as a way to teach their students, there are ways to do that ethically, and there are ways to do that are not ethical. It is well documented that mamas of color are more likely to be experimented on, and for students to be the ones who are performing procedures on those mamas and on their bodies for learning, and that is just atrocious and absolutely not okay. If that's something that you don't want, you can say, I decline the presence of students or additional staff on your birth plan, and then have an advocate that knows that that is your preference. We're not allowing any student to do anything to your body in labor. And like I said before, there are ethical ways for a student to be present for birth, and that's okay if that's something that you want, but just know you have the right to refuse that if you don't want it or you don't feel safe with it. I also recommend that everyone memorize the post-birth warning signs, because maternal mortality doesn't only affect moms when they're in pregnancy, when they're in birth, but also after they have their babies. P is pain in chest. So if you're having any pain in your chest, we want to go to the ER. O is obstructed breathing. S is seizures. And then T is thoughts of hurting yourself or someone else. POST, post-birth warning signs. So if you're getting any of those signs, those are emergent, and we need to go to the ER immediately. Preeclampsia can affect someone, or eclampsia can affect someone after they have their baby. There are other different kinds of conditions that can pop up after you have your baby. So memorizing those signs and acting quickly is really important.